Welcome. I'm Susan Lieberman, Vice President of Practice Resources at Conventus Inter-Insurance Exchange, and I'll be your moderator for this webinar. Thank you for joining us today. As you may know, billing and coding audits with pre- and post-payment demands are really rapidly increasing for all physician specialties. And unfortunately, no provider is immune, regardless of the size of your practice. And the consequences really can be severe. We've actually seen seven-figure post-payment demands up to $2.6 million. So this is a very significant topic that we're talking about today. That's why we've been giving a series of webinars on billing and coding, such as audit red flags and trends that we've seen, as well as what to do if you get a risk adjustment audit letter. If you are not a Conventus insured member, it is suggested that you contact your malpractice carrier to determine if you have billing errors and omissions coverage, and if yes, what are you covered for. And if you missed any of our previous webinars, you can still access them at your convenience on the Conventus website at www.conventusnj.com. But today's webinar is going to be a bit different. The biggest issue we continually see in these audits is that the documentation does not justify the chosen coding. So we're going to do a review and a step-by-step of the documentation requirements to support the coding. But please be aware that the information presented today is for educational purposes only. Statutes, laws, rules, and regulations do frequently change. Therefore, we're not providing advice in your particular situation, so we suggest that you seek assistance from experts in the field, such as billing and coding consultants, specialists, attorneys, and others about the needs and issues pertinent to your own practice. But before we begin, I'd like to review a few housekeeping items with you. If you're having technical difficulty during the webinar, you can call the number on the slide. That is 732-362-5724. If you can't see the webinar slides, you can still listen to the audio portion of the presentation. You should be able to go to the handout section, the handout section on your webinar control menu panel and get the handouts for today's webinars, which include the slide deck and a documentation worksheet used by auditors. The webinar control panel is usually located on the right side of your screen and can be expanded or hidden. If you would like to listen to this presentation again, it will be archived on the Conventus website, usually sometime after the webinar, around 7 to 10 days. Also, because we have several attendees today, the phone lines have been muted to avoid background noise, which will allow everyone to hear better. However, throughout the presentation, please feel free to type your questions into the questions window pane on your webinar navigation control panel. This way, we'll be better able to tailor the material to your needs. At the end of the presentation, we will address as many questions as possible, and as time allows, if there's any questions left over, we will attempt to get you the answers at a later date after the webinar. You will also be asked to complete a very brief survey immediately following this webinar, and your feedback is important to us, so please take the time to complete it so we know what topics you'd like to hear next, and in order to better serve you and improve the webinars for you. For those who may not be familiar with Conventus, I'd like to briefly highlight some important services that we provide. Conventus is a 100% physician-owned and governed medical professional liability insurance company domiciled here in New Jersey, but we are really more than a malpractice carrier. Conventus is dedicated to helping physician practices with their daily challenges, and it is an increasingly difficult environment, especially regulatory environment, to operate in. In order to assist with this, I'm not going to go over everything, but Conventus members and practice managers receive services tailored to your needs, such as for Conventus members, if you do receive a risk adjustment audit letter, please call us ASAP, as we can help you through it with a real hands-on approach, because you do have billing coverage for this. We also have complimentary consulting services as a member benefit, such as to help you with MACRA and MIPS requirements, and to provide assistance with implementing the out-of-network law in your office, as well as other consulting services. And I'd like to mention that we have a strategic partnership with experts in the field, such as today's speaker, Cindy Grew. Cindy is President and CEO of Healthcare Practice Management, Inc. She currently manages 49 different multi-specialty practices in the tri-state area and Florida. HCPM also contracts with private practices and groups for consulting assignments. And Cindy has been on the board of the Healthcare Billing and Management Association and currently chairs the Publications Committee. Cindy also has billing services, and this is also a revenue cycle management company. So now I have the pleasure of turning the program over to Cindy.
Thank you, everybody, and welcome. And thank you, Susan and Convetus, for inviting me to present to your members today. I wanted to first go over what we're going to learn today. We will start with the auditor's tool utilized to review your documentation. When asked to present on this topic, I thought, what's the best way to teach you how to get paid for your services and be able to keep that money? And the handout that's provided is an auditor's tool instruction that they walk into your office with in hand to review your charts and determine, based on what they can pull from your medical records, did you bill appropriately and receive the appropriate documentation? I will let you know that the slides are very full of information, of which I do apologize on the front end. Normally presentations are bullet pointed and open for more discussion, but I felt that this information is so important to each and every one of you that I wanted you to be able to use this in the future as a reference tool in addition to your auditor's instruction sheet. All right, we're going to go over to general principles of E&M coding and documentation, the documentation guidelines to establish the appropriate level of service. We're going to talk about NEAT, the guidelines to accurately evaluate and document for chronic diseases. Additionally, we'll talk about the hierarchical conditioning coding and why it's important, as well as the use of modifiers 25 and 59 and the avoidance of billing risk adjustments. Evaluation and management coding was actually introduced in 1992, 27 years ago. The E&M codes range from 99201 to 99499. These codes can be found in your CPT book, which is updated every year. And notice I have bolded and italicized every year. It's extremely important that your office obtains a current CPT book as well as your ICD-10 books, because the codes change, the descriptions change, new codes are added, and this is what determines how you get paid and paid appropriately. The E&M codes are designed to classify services provided by physicians in evaluating and managing their medical care. In order to pick your level of service, you're really going to work on what are the key contributing components of the physician's service, which will then drive the level of service that is appropriate to be billed and reimbursed for. These codes are utilized to receive reimbursement for the services provided. Now, these next two slides basically are the structure of the book for your E&M categories, because they're based on site and or type of service. So, for example, your office and other outpatient services, your E&M codes are for new patients 99201 to 205, established as 99211 to 215. And then as we go across the grid, you have your hospital codes, consultations, emergency department, nursing facility, and domiciliary care codes, as well as prolonged services face-to-face, preventative medicine, newborns, non-face-to-face services, which include telephone services and online medical evaluations, your care plan oversight, special E&M services, home services, and other. It's important to follow the structure of the book, because it will drive and point you in the direction where you need to be, depending on the service and site of location. Note, all of your E&M services begin with a 99 code, and each code provides a description of that code, which includes the site and the type of service and the level of E&M performed. The content of each description will provide key components and contributing components to the service. Those are important words to remember as we go throughout this presentation. Each code will provide an estimated time generally required for the physician to complete the time. Those are guidelines that can be an overall contributing factor of the service provided, which we'll go into further detail in the presentation. For your office visit levels, you have new patients, 5 levels of service, 99201 to 205. A patient becomes a new patient if they have not had any service provided by that physician or a member of that group in the previous 3 years. Your established patient services are 99211 through 215. The higher the level of code, the more complex the visit. Your well visits are physicals. They're selected based on the age of the patient and if they are a new or established patient. I'm listing 99214 and the next slide is 99215. We're not going to go into details specifically, but I want to give you an overview of what it looks like. So your 99214 is your office visit that requires 3 key components: detailed history, detailed physical exam, medical decision-making of moderate complexity. Usually the presenting problems are 25 minutes spent face-to-face with the patient and or family. This is the next to the highest level CPT code for reimbursement purposes. As we go through the presentation, I will explain to you how you get to a detailed history, detailed physical exam, and medical decision-making of moderate complexity. Okay, 99215 happens to be the highest level code and obviously the highest reimbursing code. This includes a comprehensive history, comprehensive physical exam, and medical decision-making of high complexity. And usually the presenting problems are 40 minutes spent face-to-face with the patient and or family. Again, these are guidelines, and we'll talk about more in detail. Okay, now this is where I want you to use your auditor's instructions documentation to follow with me as we go through the 7 components of the documentation of E&M services. We'll go through history, examination, and medical decision-making, which consists of pages 1 and 2 of the auditor's instructions. And then we'll touch on counseling, coordination of care, and the nature of the presenting problem. And lastly, time and the importance of that. How do you choose your exam level? 3 key components for each level are history, examination, and medical decision-making. If you address your page 1, you'll see at the top your history, and we'll go through those components, and then at the bottom it starts your exam, and then on page 2 it goes through your medical decision-making. So you can follow along with me. Contributory factors are for the majority of the encounters include counseling, coordination of care, and the nature of presenting problems. It is not required that each of these services are provided for each exam. Now we'll get into the nature of the presenting problem. When the patient presents in your office, the presenting problem could be one of 5 categories. It could be minimal, self-limited or minor, low severity, moderate severity, or high severity. Minimal really doesn't even require the presence of a physician. Self-limited or minor is not likely to cause permanent health, alter health status. The problem runs a definite and defined and prescribed course. Low severity, there's no risk of mortality, usually full recovery without functional impairment, up to high severity, which could have moderate to high risk of mortality without treatment, or high probability of severe functional impairment. So that's your scale of 1 through 5 for the nature of the presenting problem. All right, now we can work on our form. So at the top, in the top left, you'll see there's 4 types of history. We have a problem-focused, expanded problem-focused, a detailed, and a comprehensive. So under the history section to the right, center of the page, you're going to see those words: problem-focused, expanded problem-focused, detailed, and comprehensive. We're going to work backwards as I go through the process to determine the information that's documented in the exam and to how you get credit for that. Under the type of history, each type of history includes a chief complaint, the history of the present illness, as you can see on the left-hand side, HPI, the review of systems, and the PFSH, the past family and or social history. The nature of the presenting problem will determine the extent of the present illness, the review of systems, and past family and or social history that's obtained and documented. Let's start with the chief complaint. The chief complaint must be documented for every encounter. The minute an auditor pulls your record, if there's no chief complaint, you're not starting off on a good foot as far as being able to support any level of service that you have billed. It's a concise statement describing the symptom, problem, condition, diagnosis, or other factors that is the reason for the encounter, and it's usually stated in the patient's words. Okay, now, history of present illness. It's a chronological description of the development of the patient's present illness from the first sign or symptom to the present. If you look at your form, you're going to see HPI, history of present illness, and their elements. And to the right of that, we're going to talk about brief and extended. A brief HPI, your medical record should describe 1 to 3 of these elements of the present illness, whereas an extended HPI should describe 4 or more of these elements. And the elements include location, quality, severity, duration, timing, context, modifying factors, and associated signs and symptoms. So basically, when the patient is there, you're asking these types of questions. What's wrong? Where is it? It's my right ankle. What's the quality? It's aching, burning, radiating pain. What's the severity? I've got a 10 on a scale of 1 to 10. How long ago did it start? 2 days ago. What's the timing of it? It's consistent or it comes and goes. What's the context? How did this happen? Lifted heavy object at work. Modifying factors, it's better when I apply ice. And associated signs and symptoms, numbness in toes. Again, to get to the brief history, you only have to document 1 to 3 of those elements, or 4 or more for an extended history. And the auditor will go through and read all of your documentation, and she or he will be checking off these boxes to determine, is it 1 to 3 or 4 or more? Then we're going to move on to the review of systems. The review of systems is actually an inventory of the body through a series of questions seeking to identify signs and symptoms. We have 15 review of systems. And if you look to the right, we will talk about how to get to a pertinent to problem, extended, or complete. So a problem pertinent review of system inquires about one of the systems directly related to the problem. So they only have to talk about one thing. Patients here today, they have an eye issue. If that's all they're talking about, we're starting with the problem pertinent review of systems. To get to an extended review of systems about the system directly related to the problem in the HPI, and then a limited number of additional systems need to be discussed and documented. You can have a patient's positive or negative responses documented for 2 to 9 of those 15 systems. that would be an extended. And to get to a complete review of systems, you will discuss at least 10 organ systems that must be reviewed and documented. And for the remaining systems, a notation indicating all other systems are negative is permissible. So you're covering all 15, and you must document at least on 10 of those. So in the absence of such a notation that all the rest are negative, you must at least document 10 systems individually. Okay, now we're going to move on to the past family and or social history, which is the box below the review of systems. Again, we have pertinent or complete. When we talk about the past history, the patient's past experience with illness, operations, injuries, or treatments. A family history, review of the medical events in the patient's family and include any diseases that may be hereditary or put the patient at risk. And social history is age appropriate, review of the past and current activities. To obtain a pertinent past family social history, at least one specific item from any of these three must be documented. If you're in a category of subsequent hospital care, follow-up inpatient consultations, and subsequent nursing facility care, the CPT book only requires that an interval history be documented. It's not necessary to record this information about the PFSH for every visit. In order to obtain a complete past family social history, you have to have at least 2 of the 3 histories above documented for an office visit, emergency department, subsequent nursing facility care, domiciliary, or home care. Again, the auditor is going to go through and check off these boxes for the past history, the family history, and the social history. Have you documented appropriately? If none of that, then they're going to check off the none box. If you have one history area, you're going to be pertinent. And then to have complete, you have to have 2 or 3 history areas to hit the comprehensive level of that service you're providing. Documentation of the history is the chief complaint is indicated at all levels. So again, this slide will show you basically the same information on the auditor's instructions on the right-hand side. In order to obtain a problem-focused type of history, you have to have a brief history of the present illness, and you're not required, it's not applicable for review of systems or past family social history, and so on. To get to a comprehensive, you have to have an extended history of the present illness, which was 4 or more systems, a complete review of your systems. Again, you have to have 10, and the past family and social, you have to have a complete as well, 2 of 3 of the history in order to get to that comprehensive level. Okay, now we're going to move on to the examination. Again, there's 4 types of exams. So if you look at the bottom portion of page 1 of the auditor's instructions, we will be talking about the problem-focused, expanded problem-focused, detailed, and comprehensive exam. Again, that would be on your right-hand side. You'll see those words at the bottom. And then above that, to obtain a problem-focused exam, you have 1 body area or system that's affected. To obtain your expanded problem-focused or detailed, you have up to 7 systems that need to be documented for the affected body area or organ or other symptomatic or related organ systems. And to obtain the comprehensive level, you have to have 8 or more systems under the general multi-system exam or complete exam of a single organ system. Under the examination of the body areas, we have 7 areas that need to be documented or could be documented. So if you document 1, you're sitting at a problem-focused bullet. If you document up to 7, then you are now at the expanded problem or detailed. We go on to the organ systems recognized for the purposes of this exam, and there are 12 of them. And again, you would go through up to 7 or 8 or more and get those check boxes to determine which level you've actually supported in your documentation. 4 seems to be a popular number because there's 4 types of medical decision making as well. Medical decision making is the last key component, as we talked about in several slides ago. That's the determining factor that's going to pull all of this together. So if we look at page 2 of your handout, the medical decision making, we're going to walk through the straightforward, low complexity, moderate complexity, and high complexity. The medical decision making refers to the complexity of establishing a diagnosis and or selecting management options. 2 of the 3 elements in the table must be either met or exceeded. You have straightforward, you have number of diagnostic or treatment options, minimal. The highest risk of complications and or morbidity or mortality is minimal. And the amount of complexity of data to be reviewed is minimal or low, up to the level of high complexity where we have extensive across the board. Now let's talk about the details of the medical decision making. The number of diagnosis codes or management options are based on the number and types of problems addressed during the encounter, the complexity of the establishing a diagnosis, and the management decisions that are made by the physician. The amount and or complexity of the data to be reviewed is based on the type of the diagnostics testing ordered or reviewed at that time, the decision to obtain and review old medical records, and increases the amount of complexity of the data to be reviewed. And the risk of significant complications, morbidity, and or mortality is based on the risk associated with the presenting problem, the diagnostic procedures, and the possible management options. I want to just jump off slide for a moment and give you a couple tips on documenting for your medical decision making. Really, at this point, you are establishing in your mind what you are doing to treat your patient and based on their presenting problem. A lot of times what we find in working through cases that we have to help practices support that documentation, where insurance companies are coming in and asking for money back because after review of their chart, the documentation is not supporting what that level of services that was billed. So in your medical decision making, you want to note statuses of conditions, stable, mild, chronic, with inadequately controlled symptoms or persistence. Note status of conditions, responses to current management, patient and caregiver concerns. I mean, especially as our parents get older and we take our parents to our doctors, we might have concerns for their certain situations that the patient's not aware of, that we're now going to be discussing with the provider. That type of information needs to be documented to support the medical decision making necessary to pick your appropriate level. If you have to refer the patient out to consult for others, include the reasons why you made that decision to do that. No complicating factors. If a patient or a caregiver is non-compliance, I mean, that is huge if they're not taking their medicines as appropriate. All of that information should be documented to support your medical decision making. All conditions that were addressed need to be in your assessment and your plan. And this is where, especially for a practice that does not utilize an EHR, where we see that information is probably running through their head. They've done this day in and day out. It's not on the paper. And, they've been able to make their decision based on their experience and what have you. But if it's not documented for an auditor to be able to review, I mean, that auditor is not able to assume anything. If it's not there, you're not getting credit for it. Okay. I included the table of risk, and I'm not going to go through all of this because that is part of the handout. I included it just in case you didn't have that availability and you needed to refer back to the slides. It's there for you. Now let's talk about time. Time is a good thing. when a patient is there and your provider is spending more time than we can support based on the examination or the review of systems and the past family social history, to be able to be reimbursed for the now time that we're spending. So when you consider counseling and or coordination of care that dominates more than 50%, that is the key. More than 50% of that encounter with the patient and or family, the face-to-face time in the office or other outpatient setting or floor unit in the hospital, then time shall be considered the key or controlling factor to qualify for a particular level of service. For example, a 99215 is a 40-minute, quote-unquote, exam. But if you can't support everything that falls under that 99215 documentation requirement, you can then use this as a controlling factor as long as it's documented appropriately. The face-to-face time includes time spent performing tasks such as obtaining history exam and counseling the patient. Also time spent doing work before and after the visit, such as reviewing records, tests, arranging further services, communicating with other professionals and patient through written reports and telephone contact. If you're in the hospital and you have non-face-to-face unit and floor time, it includes time present on the patient's hospital unit and at the bedside rendering service for the patient. The time is established and review patient chart, examine the patient, write the note, and communicate with other professionals and the patient's family. I wanted to give you some examples of proper documentation when you're using time as your key factor. I spent 30 minutes face-to-face with the patient and over half in discussion of the diagnosis and importance of compliance with the treatment plan. You have indicated to the auditor your exact time. I spent 30 minutes on the unit, over half in counseling the patient and or coordinating her care and follow-up after discharge. Again, more than 50%, and how much time did you spend, and what were you doing in that time? Avoid using for all visits, and avoid using the same time for all visits. Not all visits are 15 and 25 minutes. And most importantly, not all visits are dominated by counseling the patient. So as you go through your documentation, your documentation is that medical record that if that patient presents in your office today and needs to take that to another provider, that provider of service needs to be able to understand what this patient has gone through in the course of treatment with you as their provider. And if you don't document it, the patient has no medical history to take with them. So always remember the importance of the documentation. Let's talk about meat. Meat really is better when it's well done. Now, I'm not a meat eater, and when I am, I like it not as well done, but in this case, that's what you want to remember. Meat needs to be well done. It's the official ICD coding guidelines that state the condition that must be present at the time of the encounter, affect the patient care or management, and be clearly documented in order to code as a diagnosis. One of the areas that I find in reviewing charts for practices, especially within the EHR, is I might have a list of 20 diagnosis codes. And those diagnosis codes are meaningless because nothing is documented in the plan and assessment of care. They're not talking about what they're doing regarding those diagnosis codes or the medications that those patients are taking for those diagnoses. So it's very, very important to remember the meat. The diagnosis must be based on clinical medical record documentation from a face-to-face encounter, as well as, let's see what happened to my cursor. Oh, there we go. A well-documented progress note would include the HPI, the review of systems, the physical exam, and show the medical decision-making process. Each diagnosis must be documented in the assessment and care plan. Each diagnosis must show that the provider is monitoring, evaluating, assessing or addressing or treating the condition, which is the acronym for MEET. Monitor, evaluate, assess, or treat. This is my famous last words. Paint the picture. If it is not documented, it didn't happen. And that's why I thought it was important for you to understand what an auditor looks for when they come in and pull your chart. They're going to take this form and walk through everything that we've gone through so far to determine the level of service that you have billed. And does it match? And did you paint the picture that they can actually understand why the patient was there and the severity that supports the level that you have billed? So when we monitor signs and symptoms, we're talking about disease progression, disease regression, and the evaluation portion, we're looking at the test results, the medication effectiveness, and the response to any treatment that we have recommended. We're going to assess and address. We're going to order tests, discussion, review records, and counseling. And treatment for medications, therapies, and modalities. So if you remember the importance of MEET, that will help you in your thought process when you're documenting. Simply listing every diagnosis code in the medical record does not support a reported hierarchy coding category, which we will talk about. An acceptable problem list must show evaluation and treatment for each condition that relates to ICD-10. And as you will know, or as you do know, the ICD-10 really has changed our world as far as why it's important to document in detail. And they even changed the HCFA form to include up to 12 diagnosis codes to support what you are billing. And that's all fine, well, and good as long as your documentation spells out the picture of what your thought process was in the MEET process. Let's talk about risk adjustments and how it impacts your payments. Risk adjustments is a model that CMS uses to adjust capitation payments to the private healthcare plans for the health expenditure risk of their members. So your Medicare patients who join a managed care plan, CMS uses this model to determine how much they're going to pay them and what the cost of treatment will be based on the type of diagnosis categories. CMS measures the disease burden that includes 79 hierarchical of coding categories, which are correlated to the diagnosis codes. There's over 9,500 ICD-10 codes mapped to one or more of the 79 categories. Patients can actually have more than one HCC category assigned to them. We talk about chronic conditions that Medicare Advantage plans expect to be documented in their chart. Include diabetes without complications, chronic obstructive pulmonary disease, congestive heart failure, breast cancer, ischemic heart disease, and angina. So those are the areas that, as you treat your patients, when they come in and audit your records, that's what they're expecting to see in your documentation. The hierarchical coding category key points are that the ICD-10 codes are mapped to these conditions and are used to determine the severity of illness of patients' panels. This will affect our future payment models. New payment models include risk adjustment factors for the patient's health status. Physicians should report not only the diagnosis codes that describe why a patient was seen, but also any diagnosis codes associated with chronic conditions that affect treatment choices. Patient risk scores are reset each year, so the physician should comprehensively code chronic conditions at annual visits. It's extremely important because that drives the financial impact that the plans have, that the payers eventually reimburse to our providers for services. And so we need to make sure that our documentation is supporting that information as we move forward. So each patient is assigned a risk score based on their demographics and health status. Demographics including their age, their gender, whether they're dual Medicare or Medicaid eligibility, a patient's residence, where they live, are they in home or an institution, and their current health status. Okay, as we move on, I want to discuss some of the modifiers that impact your coding and your reimbursement. Modifier 25 was a very helpful modifier when it was instituted, because there were more times than not that providers were doing more than one service while the patient was presented in the office, and they were not getting compensated for that. So the modifier 25 was established. The definition of modifier 25 is to have a significant, separately identifiable evaluation and management service by the same physician or other qualified healthcare professional on the same day of a procedure or other service. By attaching a modifier 25 to your E&M code, you are telling that insurance company that you have done a significant, separately identifiable E&M as defined or substantiated by documentation that satisfies relevant criteria for the respective E&M service to be reported. The E&M may be prompted by a symptom or condition for which the procedure or service was provided. And a different diagnosis is actually not required for reporting of an E&M service on the same date. A lot of times, here's a good example of using a modifier 25. A patient presents, they come in to see the doctor, they have a cold. While they're there, they're in discussion, and they might say, I found this skin tag on my neck, and it's driving me crazy because my necklace keeps hitting it, and it's very annoying. Instead of bringing the patient back to remove that skin tag, they can actually perform that procedure on that day and be reimbursed for both, as long as the documentation supports that they were being treated for their cold and then identified another situation for the skin tag removal, and then that service is documented. Then it would be very appropriate to put modifier 25 on your E&M service and expect to be paid for both. People who are not aware of the modifier usage, I tend to find where they'll put modifiers on the wrong service. A modifier 25 will only ever be attached to an E&M service, not the additional service provided, and not both. Do not use modifier 25 when billing for a service performed during a postoperative period if it's related to the previous surgery. Modifiers, the use of modifiers will come after the understanding that there's no other CPT code available to be used. And that's just an indicator to the insurance company that you need to communicate to them that this is something out of the ordinary, something significant and different. You don't ever want to use it if there's only one E&M service performed during the office visit and no procedure. So there are times where people are putting a modifier 25 on an E&M service when nothing else was performed that day and or billed for. And so that's an indication to the carrier that you in your office may not know what you're doing, which could then trigger an audit for them to come in and review your records. Do not use modifier 25 when a minimal procedure is performed on the same day unless that level of service can be supported as significant and separately identifiable. Our most common misused modifier is modifier 59. Modifier 59 usually is the last modifier of choice because it is commonly misused. We'll go through some areas where you should not use it if a more appropriate modifier is applicable. So I've seen it used where it could be right and left versus they'll put on the modifier 59 to indicate, like we've done two of these, but the more appropriate modifier would be right to left. So 59 would be your last choice. Use right and left before that. And you should never use modifier 59, quote unquote, to get a claim paid. Modifier 59 basically unbundles billable codes. Modifier 59 is useful, and I'll give you a good example here in a minute, but if used inappropriately, will unbundle a code in order, quote unquote, to get that claim paid, when in essence, that should not have been an unbundled procedure. Yes, the provider did the service, but it was inherently part of the overall service. Here's a good example. In a surgical situation, a provider goes in to deal with a gallbladder and opens the patient up, and by the time he tries to get to the gallbladder, there's lysis of adhesions that he has to get through in order to get to the organ. Well, the lysis of adhesions are considered inclusive in that surgery. They're not going to pay you to get through the lysis of adhesions in order to get to the organ. It's confusing because there is a CPT code for lysis of adhesions, and you will get paid for that if that's the only reason you are going in and performing that surgery. So the code does exist, but because it exists, it doesn't mean that it gets paid every single time you have to utilize lysis of adhesions in order to get to the organ that you need to be performing surgery on. Those are considered bundled codes. And your CCI edits, there's national CCI edits, you can Google that, you can get a list, they'll show column 1 and column 2 codes. Your column 2 codes are normally combined with the column 1 code that says it's a component part of it. It will also have an indicator if you can use modifier 59 to unbundle it, but you have to have a reason to do that, and it needs to be documented so that can support it. It is normally used to indicate that 2 or more procedures were performed during the same visit to different sites on the body. An appropriate use of modifier 59 would be for a dermatologist performing a photodynamic therapy session on a face and scalp, and then performing the same procedure on an extremity. You would code it as 96567 and 96567 with modifier 59 on the secondary procedure, not on the primary. It's a distinct procedural service. It's used to identify procedures and services other than E&M codes that are not normally reported together, but are appropriate under the circumstance. Common use of modifier 59 is for surgical procedures, non-surgical therapeutic procedures, or diagnostic procedures that are performed at different anatomical sites, are not ordinarily performed or encountered on the same day, and that cannot be described by one of the more specific anatomical modifiers. Example, right, left, E1 through E4, which is your eyelids, and etc. The documentation must support a different procedure or surgery, a different site or separate injury or area of injury and extensive injuries, not ordinarily encountered or performed on the same day by the same individual. And it's interesting because after modifier 59 came out, then modifiers XE, XS, XP, and XU actually became effective January 1st of 2015. These modifiers were established to provide greater reporting specificity in situations where modifier 59 was previously reported and should be used in place of modifier 59. Now, again, it became effective January 1st, 2015. I will tell you, in all my years and the practices that I currently work with, I don't remember any of my providers using these modifiers. And the reason, when they first came out in January of 2015, is the insurance companies really were not set up yet to accept those modifiers until I just received a news bulletin that effective April 12th, Independence Blue Cross will start denying single-line claims that are billed with modifier 59. And I'll explain that in a second. Let's see. Oh, let me back up. Okay, so in XE, the reason they're highlighted in red is because that will help you remember the use of these 4 different modifiers. XE is a separate encounter on the same date of service. XS is a separate structure, separate organ or structure. An XP is a separate practitioner, service performed by a different provider. And an XU is an unusual, non-overlapping service. Now, when we talk about Blue Cross sending out this bulletin that just came out this month, that they will deny single line claims that are billed with modifier 59. You want to keep in mind that your claim form only has the availability to put, I believe, 6 line items on one claim. And you could have a plastic surgery practice, for example, that does numerous removals of lesions and what have you, all in the same encounter. And therefore, it would expand, if you actually printed it out on paper, it would expand over to 2 claim forms in order to list all of those CPT codes appropriate. And if your claim forms happen to print out and the last line item is a single line that has a modifier 59, it will be denied. They will not pay for that line item. So you have to be very careful when you are doing your billing in those types of situations that that line item will not be considered by itself because they are component parts of other CPT codes. So just I thought that was very interesting. And it's the first communication since actually 2015 that I've come across where insurance companies are supporting now the use of the XE, XS, XP, and XU. They're hoping that these modifiers will help educate providers really what the true use of modifier 59 was meant to be. Okay. Now it seems like we are actually ready for questions, but I'm going to just take one quick, but I want to share some examples with you of those modifiers, the XE and the XP, of what that looks like and when you would use it. So for example, an XE modifier could be used for a surgery operative session. One surgery procedure is at 9 a.m. and one is at 6 p.m. So it's separate encounters on the same date of service. An XP would be separate practitioners on the same date of service. A patient seen by her OBGYN during an exam and the doctor notes an issue and requests his partner, who's a periodontologist, to examine the patient as well. So in that case, you're billing for 2 providers in the same practice on the same date. You would indicate with an XP modifier to notify the insurance company of the uniqueness of that situation so that they're not automatically bundled. An XS is a separate suture or a structure or organ, different anatomical site, same encounter. Patient presents and they have an injection in the tendon sheath elbow and then an injection in the tendon sheath of the knee. So same procedure. The second procedure would be indicated with an XS modifier that it's a separate structure or organ. And another example for an XU modifier, same encounter, same practitioner, same anatomical site. It's a different diagnostic procedures performed based on the findings of a therapeutic or surgical procedure required on the same day. So for example, a diagnostic cardiac catheterization is followed by a medically necessary cardiac procedure. So in order to be paid for both, to indicate that these are 2 distinct, different services provided, the second one would be appended with modifier XU. Okay. I also want to take a few minutes before we open it up for questions. I know we have a little time, so I'm pleased about that. To also discuss some of the information that providers don't necessarily would not understand going through the auditor's guidelines that are key pictures to you getting paid and keeping your money. Again, I can't stress enough, paint the picture. The key piece that supports the level of the nature is the presenting problem and your medical decision making. Actually, CMS actually came out in November of 2017 stating that they were going to make changes that they're recommending and voting on how to make changes to those 5 levels of service between new and established patients, and doing a combination coding, because they do realize that the documentation requirements are erroneous. I mean, it does take time to document. You need to have a system in place to be able to support what you are doing and to keep your money for that. But based on that, they're saying that if they take away this documentation requirements that's so heavily weighted right now on your higher level E&M services and combine them, say a 99213, 4, and 5, then they would say that your documentation only has to support a level 2, and for any of those 3 codes, we'll pay you a combined rate. And then that didn't go over very well. Then they came back and said, all right, we would look at combining 99212, 213, and 214 together and leaving the comprehensive 215 alone, and then sharing a combined rate with that. As a provider, that would help you from a documentation requirement standpoint, but depending on the severity of your patients that you treat, it could have a huge financial impact on your practice. I will tell you that I did an experiment with one of my practices when this information first came out, and surprisingly, he would have lost, I believe, $811 annually based on that new presentation. So it wasn't as drastic as we thought it would be, but it also is going to have an impact. And it's not been finalized yet, but CMS is looking to make these changes in the future. And so at any point in time when it's open for comment, providers should voice their opinion as to what's working for them and what's not. But until that time happens, really your documentation needs to be able to meet the guidelines for the auditors to be able to support the level of service that you're billing. And if you utilize the rules that they have published for you to utilize, you'll be fine. And you'll be able to continue to practice viably and not be in a position where an insurance company comes back and wants to extrapolate over 5 years because you had I'm picking a number, 85% of the E&M services that you billed were not documented appropriately, and they're going to go 5 years back and say, well, we paid you X amount of money, and now, based on what we just uncovered in our small audit, we're going to extrapolate, and now you owe me hundreds of thousands of dollars back because we overpaid you based on what your documentation supports. And that's a real picture. So I hope this information has been helpful to all of you. And I hope that this will continue to give you the guidelines that you need to be able to continue to care for your patients and be paid appropriately for the services provided. Thank you very much for all of your time. I look forward to any questions, and you have my contact information if anything comes up later that you would like to reach out to me.
Thank you, Cindy, for presenting this very important practical information for both providers and staff on coding documentation. So we're going to open it up to Q&A right now for everyone, and this is your opportunity to get your specific question answered. Remember to submit your questions in the question pane in the webinar control panel. Also, I do want to remind you, in the webinar control panel, there is a section called handouts, and today's webinar slides are in there, as well as the audit sheet that Cindy has been referring to all along. So please remember to open that up and save it on your computers or print it out. So,
and the last thing I wanted to also share was that I did provide coding fact sheets.
Yes.
That is also like a cheat sheet guideline that Combatis will provide to all of the attendees as well after the presentation.
Yes, so that will come after the presentation. Give us a couple days, but that is going to come after the presentation. And that's CMS's documentation fact sheets for CPT codes 99205, 99213, 99214, and 99215. So that will be coming afterwards. Right now I'm going to go to some questions that we have. Here's one. If a SNF patient has been cut for insurance benefits and the facility requests that the consulting doctor appeal, can the time be billed, which would include discussing with case manager, therapists, call to the insurance company, etc., to discuss with the insurance doctor, I assume the medical director, and then talk to the facility case manager to advise of outcome. This may be in person or by phone, and the patient may be seen on that day.
Okay, I would say yes. I mean, you can bill based on documentation. I mean, based on time, as long as you document exactly what that time involvement entailed. Who I spoke to, why we made these calls, that question that you just asked that was very informative should be documented. This is why I'm doing this. Because when the auditor looks at that, if your examination of that patient did not support a level, but you have spent X amount of time, so let's say a 99214 or 99215 is 40 minutes and you've spent 40 minutes plus on this transition care and what have you, then yes, you can document that, but just include the details that support what you're doing and who you're discussing with and why.
Also, we got the same question. Can you still use a code such as 99307?
I'll tell you in a second. I'm just grabbing the coding book specific because I want to see if that has a timeline on it.
Okay. Should we go on to the next question, and you can come? We can always go back to that, or get to the or send that information out later.
Yes, 99307 does have a timeline on it. Usually the patient is stable, recovering, improving, typically 10 minutes at bedside, and the patient's faculty floor or unit. So yes, your subsequent nursing care codes do have your timeline on it, and you can bill appropriately based on the time.
Okay. Thank you. Next question, if a doctor does an exam and then determines an injection is needed, would XE be used on the injection code?
No, if it's not normally a bundled code, you would not have to use XE. XE is basically saying this would normally be a bundled code where I would normally use a modifier 59. So an injection has its own code, it is not bundled. And again, your CCI edits will help you with that if you have any questions regarding is it bundled or is it not bundled.
Okay, last question is what portion of the history two-part question, what portion of the history can be copied from previous documentation, and what portion can be documented by the medical assistant?
Okay. Well, it's interesting when you get into the copying and carrying forward of information. Basically, anybody can document the review of systems in the past family social history, but the provider must review and indicate that this was reviewed in their notes. Additionally, the patient can complete a questionnaire. So if you have a form that the patient fills out and they go through and complete this past family social history and review of systems, that can be incorporated into your record as long as it is documented that the provider has reviewed that, where they don't have to physically then turn around and document every single word verbatim in their note if you've already got it on some type of a form. It just has to be indicated. So when you copy from previous documentation, basically the auditor is looking for a tracking system. Where did you get that information? So for example, if you were taking notes from a resident and you copied that over and you don't review it or indicate that you have reviewed it, they're like, well, where did you get that from? I can't count that in your documentation for today's visit if you don't indicate that you've looked at it, you identified it, and you comment on it. If any of the information is copied forward from a previous exam, it must be documented that he's looked at it and or made changes to it. So if it's copied and then they've reviewed it and said, oh no, this has changed, or this is, I've got to add to it, then that proves to the auditor that you have reviewed that.
Thank you, Cindy. That concludes our questions. And thanks again. As a reminder, Cindy provides consulting services to both small and large physician practices, and you can contact Cindy directly. If you're an insured Conventus member and have questions, you can feel free to contact me, Susan Lieberman, directly. And as I said, you will be getting some more CMS documentation fact sheets from us within the next couple of days. Please, just a reminder, please do fill out the survey questions immediately after this webinar. There are only a few of them, and it helps us tailor and bring quality programs to you. So this concludes the webinar for today. Thank